Putrajaya.
Putrajaya. Assalamualaikum warahmatullahi wabarakatuh and Bismillahirrahmanirrahim. And thank you very much to Dr. Muhammad for the kind invitation to be here. And it's really wonderful to be in the same hall with all of you, most respected. I think before this we have met online with discussions through the guideline as well as the previous global survey discussions. So I have been given the great privilege by Dr. Muhammad to actually share with you the results of the basal insulin-only analysis from the DAR Global Survey 2022. And so as an outline, I think maybe just quickly look at the subtopics, which are insulin therapy itself and the related risks for Ramadan fasting, reflecting on the risk stratification or scoring, and also looking just quickly at the treatment recommendations specifically for basal insulin therapy that we already really know very well in the DAR International Guidelines of 2021. And just a few recollections from the DAR Global Survey of 2020 in terms of the pattern of basal insulin therapy. And really the main sharing for you today is the results of the analysis that has been recently completed for the basal insulin therapy for the most recent global survey. And we really know that the 2020 global survey reflected, Ramadan fasting right in the COVID era, whereas 2022 was the immediate post-COVID era. So this is most familiar to all of us, and we've been using this quite regularly now in the last couple of years to score our patients and to calculate their risk category, and then give us a proper recommendation to them whether it's safe or not to go ahead fasting in Ramadan. And this would be done in the pre-Ramadan period, preferably in the 2 or 3 months prior to Ramadan by the physicians attending to the patients. I highlight here the segment on type of treatment. As we know, there are 14 elements in this risk scoring, and type of treatment looking specifically at insulin. We know how we would actually calculate the cumulative score, but it makes us understand that if we were to actually try to maintain that our patients on basal insulin therapy in the pre-Ramadan period would have the greatest safety, as well as keep them in the low or moderate risk category. Therefore, we would need to ensure that certain elements would be actually scored the least. For example, they should be monitoring blood glucose as indicated. They should have glycemic control in the best of categories, and they should also not probably be having hypoglycemia. And if this was so, then the resultant calculation for that patient on basal insulin therapy in the pre-Ramadan period would still possibly be in the moderate, maybe difficult to be in the low risk category, because most of these patients may have, other, in terms of the other elements, may actually score a cumulative score that is higher. So now we look at just the type of treatment, and I've actually highlighted basal insulin, and it is going to give a score of 1.5. And we know very well that basal insulin probably represents the most frequent injectable regimen for our patients with type 2 diabetes. However, it is not often prescribed on its own. It's often prescribed in combination with other oral glucose-lowering drugs, or in fact with other insulins, for example, prandial insulin. So if we were then to look at our patients and accommodate the additional therapy, then if they were on, say, sulfonylureas, whether the longer prior generation or the newer, then you would actually increase their risk score from the type of treatment to about 2 or 2.5. And if they were on basal insulin together with prandial insulin, and that's not there for us to calculate actually, there is a basal bolus which pushes them up to 2.5. But what if they were on a basal prandial regimen? Would that equate a once daily makes insulin? That is the question. All right, so in terms of insulin adjustments for Ramadan, I think we all know very well how to do that, and these are just certain concepts that have been highlighted in the DA 2021 practical guidelines about how important it is to modify the dosing, to consider whether a modification in the dosing regimen or even the dose or the timing will be necessary in the pre-Ramadan period. The glycemic control in the pre-Ramadan period will really determine whether you want to down titrate, especially in those who are tightly controlled. But often we know from the prior global survey that many patients are going into Ramadan fasting without, tight control. So many of them are probably not requiring reduction in the dose. Yeah. And this again is quite familiar to all of you about how you would adjust basal insulin therapy. If you were, and most often now people are going away from prescribing human insulin or NPH, and that requires a twice daily injection, sometimes, more often daily. So often with a daily dosing, we would consider a reduction in dose of maybe 15 to 30%. More, of course, the timing of the basal insulin dose would be in the evening, often taken at iftar, if not later in the night. And as I had mentioned very frequently, we do not use twice daily NPH or the earlier analogs. Yeah? And there would be different sort of regimens to guide the titration as seen here that was actually recommended in the guidelines. Yeah? So although there are no sort of really head-to-head studies, there are observational studies looking at basal insulin analogs like glargine U100, the very first and often referenced basal insulin analog. But we know that it is superior in terms of preventing hypoglycemia, as opposed to NPH. With glargine U300, there was the Orion study, but that was also observational, and it was not head-to-head randomized versus, for example, other insulin, basal insulin. But we also know that pharmacokinetics-wise, that these insulins are actually much safer and have less risk of hypoglycemia, especially in the Ramadan fasting. So in fact, these basal analogs are much preferred to human insulin. Yeah, and as we saw in the DA Global Survey, I will show you the results more. It depends on which geographical area. For example, where I come in Malaysia, access to insulin analogs, especially in public hospital care, is still quite restricted. Yeah? Whereas possibly in the Middle East, more often than not, if you are prescribing basal insulin therapy, it is definitely an insulin and a basal insulin analog. So in the DA Global Survey of 2020, we can observe, as mentioned before, a huge number of almost 6,000 individuals, of which 45% or so were treated with insulin, a number of 2611. And among the insulin treated, almost 2/3 were actually on basal insulin. And that would depend on whether they were treated with basal insulin only or basal insulin together with prandial insulin in a basal prandial, basal plus or basal bolus regimen. Yeah, and you can actually have a look at this here, premix insulin about 1/3. Yeah. A bit more detail from the DA Global Survey of 2020. Among those on basal insulin, what is the pattern? So 2/3 of them were receiving analogs versus human insulin. And out of the analogs, 1 out of 2 were receiving insulin glargine. Yeah, so that is just for us to remember. This looked at basal insulin and intention to fast, or actually all insulins, in fact, and intention to fast. There's too many figures there in front of you, and I just wanted to show you that regardless of whatever insulin they were on, basal plus prandial, or premix, human or analog, the intentions to fast were actually, if you see, distributed well, 75 to 80% plus would still intend to fast regardless. Yeah, so very high rates of fasting regardless of the type of insulin that was used. Now, we are so fortunate to have a huge number sort of individuals involved in the combined survey of 2020 and 2022, a whopping more than 12,000 type 2 diabetics. Yeah? And out of this, the combined figure, you can see here that 1 out of 4 subjects in this combined cohort were on basal insulin. Yeah? And either intermediate acting, or if it's long acting, it would be analog insulin. So let's focus just on the DAR Global Survey 2022 until the very end. And here we would want to look at the analysis of basal insulin only versus no insulin at all. And this would be the big number, not really the number that fasted, but the bigger number. Yeah. So the age, you can reflect this in the mid-50s in both. If we want to sort of compare the figures there, 1,002 to about 7,000 individuals. The gender divide is similar. The BMI is also similar, reflecting overweight in WHO classification, but in our Asian context is already bordering onto obesity. The duration of diabetes, it is expected that those on insulin would really have a higher duration of disease. And certainly we can see definitely more than 2 decades, we have tripled the number compared to the non-insulin users. Yeah? And the mean duration of disease for basal insulin, again, as expected as well, is beyond a decade versus non-insulin users of 7 years or so. The A1C is here for us to reflect on. There are more that have, poorly controlled diabetes of A1C of more than 9%. You can actually look at that a row there over here, double the numbers that are having A1Cs that are in the poor level. And the mean A1C is certainly higher in those on insulin versus non-insulin. In a way, something we have expected. Now, focusing on comorbidities and complications, again, we would expect as well. Those on insulin usually have longer duration of disease, therefore the burden of comorbidities and complications would definitely be higher. So you see higher rates of hypertension among the basal insulin users, higher rates of dyslipidemia, microvascular and macrovascular disease taken. We could see, if you look at the figures, about 2 to 3 times higher rates among those on basal insulin only versus no insulin at all. Yeah? And this is important because, as we know, higher rates of cardiorenal complications would increase hypoglycemia, and also the impact or consequences of hypoglycemia are detrimental among those with cardiorenal problems. Interesting as well to note what are the combined medications that are used in patients who are on a basal insulin only regimen. And here you can see something of great concern is that 1 in 2 of patients on basal insulin are also on sulfonylureas. Yeah? And this, of course, we know will increase their risk score and therefore, predictably increase their risk of hypos. Yeah? 1 in 3 are on a DPP-4 inhibitor if they were on basal insulin. 25% were also concomitantly on a SGLT2 inhibitor together with basal insulin. And a very few number of about 8% or 1 in 12 were on a GLP1 receptor analog. The duration of fasting, we can see here that those on basal insulin only therapy, the intention to fast as mentioned was high. The mean duration of fasting was about 27 days, which is quite what we see in different surveys as well. And they did also 1 in 3 intend to fast in Shawwal. But a good number, actually about 2/3, were able to complete 30 days. The difference in terms of the full fasting is reflected in them fasting a lower number of days, you can see there. The duration of breaking of fast is almost similar in all, and the mean days of breaking of fast were about 1.7 in the basal insulin versus 1.13 days. Hypoglycemia, as you can see here, really look at that. There is doubling of hypoglycemia in the basal insulin group versus non-insulin. The number of days of hypoglycemia were not so different, yeah. And the numbers that broke fast were definitely higher 2/3 versus half of those in non-insulin, and the number who attended the emergency department hospital admission was also higher, and you can actually reflect on the difference in the days that they required hospital attendance. Yeah. In terms of time of hypoglycemia, sorry, can I just have a very 2 or 3 minutes to finish? Not very many slides left. Yeah, time of hypoglycemia and response. So as expected in our previous survey, we saw the same pattern that hypoglycemia risk is highest the longer you fast. And you can see here, there's no difference in the pattern between those in basal insulin and non-insulin. But here I would like to show in terms of their action or response. Yeah, so those on basal insulin, they actually omitted less of their medications completely versus non-insulin. Yeah. And they would stop their fasting, more so than the non-insulin, yeah. But equally, 1/3 did nothing, yeah, in terms of if they did have hypo, which is a concern. And going on to hyperglycemia quickly, the similar number of 1 in 5 experiencing hyperglycemia, similar to hypoglycemia, doubling versus non-insulin. The number of days, similar actually. And breaking of fast higher, sorry, this should be hyperglycemia, not hypo, in the basal insulin therapy group, and maybe not very different in terms of those attending emergency department. Yeah, and again, looking at the, when the hyperglycemia occurred, not very different. As expected, it would occur during the break, when eating period, yeah, following breaking of fast, but equally so in the rest of the day. Again, I've highlighted here that those on basal insulin were able to increase their insulin dose, of course, because those on medications orally should not increase their medication dose. Yeah, but again, there are 1/3 that don't do anything differently. Yeah, not even changing or getting into contact with a healthcare provider or monitoring their glucose much more frequently. So, in conclusion, ladies and gentlemen, I just sort of summarize to you to say that 1 in 4 of persons with type 2 diabetes that are fasting Ramadan are on basal insulin therapy, and 1 out of 2 of these are combined with sulfonylurea. Sorry, I just need to summarize that. About 1 in 5 experience hypoglycemia, and 1 in 5 also experience hyperglycemia. And combining that, therefore, 40% experience either one. Yeah, so fasting with basal insulin doubles the risk of hypo and hyper. And all I can say is that better patient education, dose adjustment, self-monitoring, which is addressed in the pre-Ramadan period, is really important among those on basal insulin therapy to reduce the risk of fasting and to improve their response to their hypo or hyperglycemia to enable them to fast safely in Ramadan. Thank you very much.